I'm going to continue on the same theme of HCV drug resistance, and there will be quite a bit of overlap between my presentation and the previous speakers. But what I'll try to do is provide more of a general regulatory perspective on this issue. And although this is a regulatory perspective talk, my disclaimer still applies. These are my own personal views and do not necessarily represent the official policy of the FDA. So just a very brief presentation outline. I'll first review some basic HCV antiviral drug resistance concepts that I'll refer to throughout my presentation. And then I'll spend most of my time talking about the impact of HCV polymorphisms on treatment efficacy in DAA clinical trials. And you'll see a lot of the same data that Dr. Cotoliel nicely presented, but what I'll present is actually data from FDA reviews that are posted on the Drugs at FDA website. And then I'll discuss more of the regulatory side of this and the considerations for pretreatment resistance testing. And then finally, I'll just give a very brief perspective on retreatment for DAA-experienced patients. So there's a lot of terminology that's thrown around when describing HCV drug resistance. So I thought I would just start off by just reviewing some basic concepts and definitions that I'll use throughout my presentation. So when I talk about a baseline polymorphism, what I'm referring to is a major natural genetic variant that's present in the viral population of a minority of infected individuals. And when I say major, I'm talking about the viral populations that are really prevalent in an infected individual. So this means something that's detectable by Sanger population sequencing or at a comparable sensitivity level by NGS analysis. And this is not to be confused with the low abundance minority variant that's in the underlying viral quasi-species. I'm not going to really cover any kind of clinical effects of those lower level variants that you might be able to detect by a next generation sequencing assay. And then when I talk about a treatment emergent substitution, this is an amino acid change that emerged or became enriched in the viral population with treatment in somebody who did not achieve SVR. And you'll hear the term RAV quite a bit in a lot of talks. And how I would define RAV as kind of more of a catch-all term, and this could refer to a baseline polymorphism, it could refer to a treatment emergent substitution, it could refer to one of those lower level minority variants. But what I'm going to focus on primarily are the major natural genetic variants that are quite predominant in the viral population. And when I talk about a resistance-associated polymorphism or substitution, this is an amino acid variant that is associated with treatment failure with a DAA or a DAA-containing regimen, or is associated with phenotypic resistance to a DAA. But I want to make it clear, and I think you heard this message from the previous presentation, in that the presence of a resistance-associated polymorphism or substitution in a viral population does not necessarily mean a drug is ineffective. And I'll also refer to the drug resistance barrier. This describes the potential for drug resistance selection and can be loosely defined as the number and type of viral genetic changes that confer resistance to a clinically relevant concentration of the drug. Now, this topic was also brought up in the previous presentation, and I just want to make it clear, because I'll refer to this concept throughout my presentation, that drug-resistant virus can often pre-exist. And this comes from studies that were published by Perlson and others back in 2010. So, as you all are quite aware, there are a ton of viruses produced in an infected individual every day, and with the replication error rate of the RNA-dependent RNA polymerase, we can assume that there's about 0.1 to 1 nucleotide change introduced into the genome per round of replication. And if you account for viral replication dynamics and the replication error rate, you can do some math and basically conclude that all possible single and all possible combinations of double nucleotide mutant viruses pre-exist in the quasi-species before treatment, and additional mutations may arise early during therapy as well. Now, many early generation DAAs have a low barrier to resistance in that they're impacted by single amino acid changes in the target protein, and because of this, drug-resistant virus can pre-exist and is rapidly selected by monotherapy. And this is why we need combinations of drugs with non-overlapping resistance mechanisms to prevent drug resistance selection, because the combination collectively has a higher resistance barrier than the individual drugs in that regimen. And this just shows the same concept graphically, where on the left you can see that somebody who has a predominantly wild-type viral population or wild-type susceptible population has an underlying resistant strain that basically is selected with a potent low resistance barrier DAA. And you can see this, we see this all the time in monotherapy trials, and the chart on the right I think is quite interesting because this is a nice example where a suboptimal virologic response to a low resistance barrier DAA monotherapy will actually result in lack of selection of a resistant substitution. But if you have patients who have a greater virologic response, this is the group on the right, this is the group that's actually more likely to have a drug-resistant substitution emerge, and that indicates that these patients are having greater suppression of that drug-sensitive strain and thus unmasking of that drug-resistant variant. And I think with that in mind, I think in retrospect, we probably shouldn't have been terribly surprised from some of the earlier studies of two very low resistance barrier DAAs, and that they were not widely effective in suppressing the viral population and preventing the emergence of drug resistance. Now, fortunately, as we all know, we've made it through that period in HCV drug development, and there are several highly effective interferon-free regimens that are currently available. And this table just summarizes the regimens that are recommended in current treatment guidelines. And as you can see, there are really fantastic regimens for essentially covering all major HCV genotypes and most HCV-infected patient populations. Now, unfortunately, not all of those are quite 100% effective, as you heard from the previous speaker. And in many cases, that reduced efficacy can be explained by the presence of polymorphisms in the drug target genes. So basically, almost any interferon-free DAA combination in some context can be impacted by the presence of polymorphisms in drug target genes. Now, ultimately, the clinical impact of these polymorphisms is influenced by other factors that also impact treatment efficacy, such as the disease characteristics, the activity and resistance barrier for other drugs in the regimen, as well as the treatment duration. And again, the presence of a resistance-associated polymorphism does not preclude the use of a DAA, and optimized or intensified regimens, including the addition of another DAA, the addition of ribavirin, or a longer treatment duration, can in fact overcome the presence of polymorphisms in the drug target genes. And I'll show some examples supporting these points. So one of the things we've had to think about as a regulatory agency is whether or not clinically screening should be conducted to guide the optimal use of a particular regimen. And here what I tried to do is summarize the factors that we think are most important to determine whether or not baseline screening for the presence of resistance polymorphisms is justified for certain situations. So those factors on the left favoring screening, of course, they all start off with having a polymorphism or a group of polymorphisms that show a very clear impact on treatment efficacy. As a U.S. regulatory agency, we're most concerned about those that significantly impact the U.S. population. Of course, it helps if you have an assay that's commercially available to detect those polymorphisms in clinical practice, as well as reasonable alternative treatment options in the event that you do detect these polymorphisms. Also, other factors that might support screening to guide treatment decision-making include resistance consequences of failure, limited retreatment options, or clinical consequences of failure. Screening, of course, would not be necessary if there's no clear impact of any particular polymorphisms on treatment efficacy, and similarly, if there's just simply a low overall virologic failure rate in the population. And this would indicate that any polymorphisms that are highly prevalent in the population are really not having a significant impact on efficacy. If there's no commercially available assay, it's going to be difficult to recommend screening for the presence of polymorphisms. Similarly, if you don't know what to do with those patients when you do detect those polymorphisms, and also if there are minimal resistance consequences and reasonable retreatment options are available and there are minimal clinical consequences, again, all of those factors might indicate that screening is really not necessary. Now, there are two factors that are sometimes discussed with regard to rationale for screening for polymorphisms that I personally don't think should be major considerations, and that is cost and complicating the treatment algorithm. So for cost, yes, the assays are not free, but my understanding is they're in sort of the hundreds of dollars of range, which when you put that in the context of the cost of treatment, we're talking about essentially less than a day of treatment to do a resistance test. That's not a detailed cost-benefit analysis by any means, but I have to think that if resistance testing can really help optimize the use of a particular regimen and limit the chance that someone might experience virologic failure and require retreatment with a more potent or more expensive regimen that I think in some circumstances it can be quite cost effective. In terms of complicating the treatment algorithm, yes, it does add another step to the treatment of a patient, but I want to put that into context with other things that we've dealt with in HCV. So resistance testing for a polymorphism that might be highly prevalent in a viral population is really not that technically complicated to detect. And it's certainly used all the time in HIV. It's part of standard practice in HIV. And we've lived through much more complicated things in HCV. So this is a real treatment algorithm from the days of Grazoprevir from the VA. That's really complicated. Cirrhosis determination also, which is used today, of course, to guide treatment, is also quite complicated, and it's not well standardized, and there is some subjectivity going into cirrhosis determination, yet it is used to guide treatment decision-making all the time. So I think, relatively speaking, resistance testing is really not all that complicated. So if we're in a particular situation where those factors really weigh heavily on the left side of the spectrum, then we will ask the sponsor to include language in the label that recommends screening for the presence of polymorphisms to guide the use of those particular regimens. So the first example where we recommended screening for the presence of a polymorphism in labeling was in the case of Cimeprevir plus pegylated interferon and ribavirin. And here I'm talking about the NS3 Q80K polymorphism in patients with genotype 1A infection. So as you can see here, the Q80K polymorphism in clinical trials was associated with a dramatically reduced response to Cimeprevir plus pegylated interferon and ribavirin. And in fact, these patients really didn't respond significantly better than those who just received placebo plus PR. So Q80K clearly had a substantial impact on treatment efficacy in this context. And what also contributed to the label recommending screening for this polymorphism was the high prevalence of Q80K in the US. It was basically identified in about half of the most common subtype in the US. So this is a huge patient population in the US. There were also potential resistance consequences of failure, and at the time, Grazoprevir and Telaprevir actually did represent alternative treatments because they were not impacted by this polymorphism. Now, we all know there's a much better way to use Cimeprevir today, and that's in combination with the nucleotide analog Sofosbuvir. And we learned early on that Q80K had less of an impact in this context, and we have more recent published data from the Optimus trials that provides some more clarity on this. And Dr. Kodalil showed these data as well, but what I just want to emphasize is how you see with the 8-week treatment duration, Q80K does have an impact on treatment efficacy, but when those non-cirrhotic patients are treated for 12 weeks, that impact of Q80K is lost. And this gets back to an earlier point that I made, that with a more intensified treatment regimen or a longer duration treatment regimen, you can overcome the impact of a resistance polymorphism. And similarly, patients with cirrhosis treated for 12 weeks, if they had a Q80K polymorphism, they also had a reduced SVR rate. And again, this points out how disease status can also influence the clinical impact of a resistance polymorphism. Now, the Ladipasvir Sofosbuvir regimen, this is the Harvoni regimen, is also impacted to some extent by the presence of NS5A polymorphisms. And this is showing analyses conducted by Lisa Nager of the ION-3 and ION-2 trials. And what you can see is in certain arms of these trials, you can see a fairly consistent trend that patients with NS5A polymorphisms had a higher relapse rate compared to those without baseline polymorphisms. And consistent with the earlier points that I made, the greatest efficacy impact seemed to be associated with the use of the less intense regimen, so those who received either 8 weeks or in ION-3 or 12 weeks in ION-2. More detailed analyses also demonstrated that the presence of multiple key NS5A polymorphisms, or the presence of polymorphisms that dramatically reduce Ladipasvir activity, were associated with the greatest efficacy impact. And that seemed to explain a lot of the relapses in the 12-week arm of the ION-2 trial. Now, ultimately, the impact of polymorphisms is minimized with this regimen, with those regimens that are actually recommended in labeling. So 12 weeks is recommended for most patients, 24 weeks for cirrhotic treatment experienced patients, and 8 weeks can be considered, but only for those who have a low baseline HCV RNA RNA level. And with these label-recommended regimens, there really is minimal to no impact of NS5A polymorphisms on treatment outcome, and therefore there is no need and no recommendation to screen for the presence of these polymorphisms with the Harvoni regimens that are recommended in labeling. Now, the analyses of the Vicuripac trials in phase 3 were a little bit unusual, and here I'm focusing on genotype 1A patients. As Dr. Codolillo mentioned, this regimen was quite effective in genotype 1B patients, so there were no resistance considerations for that subpopulation. And for these analyses, we looked at all 3 drug targets, NS3, NS5A, and NS5B, as well as various combinations. And the reason why the phase 3 analyses were a little bit unusual is because in the phase 2 studies, this is the 652 trial, there was really no signal of an impact of baseline polymorphisms on treatment outcome. And so because of this, the sponsor analyzed only a subset of baseline samples for the phase 3 trials, but we did find that in pooled analyses, considering all of the regimens evaluated in phase 3 and all the patient populations, and with some data extrapolation, we could estimate that the Q80K and NS5A polymorphisms did have a modest impact on treatment efficacy, and that considers all of the regimens and all the patient populations evaluated in phase 3. Now, ultimately, with the label-recommended regimens, we took a very conservative approach, and we wanted to limit the chances of virologic failure and really maximize efficacy with this regimen for all subjects, regardless of the presence of baseline polymorphisms. So for the label-recommended regimens, these are associated with about a 2 to 3% virologic failure rate overall for genotype 1A patients. And when you consider that Q80K or an NS5A polymorphism, one or more of those might be present in at least half of the genotype 1A population, with such a low virologic failure rate, this tells you that those polymorphisms are really not having that big of an impact on treatment outcome. And indeed, the sponsor has recently conducted retrospective analyses of those phase 3 baseline samples, and they did demonstrate that NS5A polymorphisms and Q80K did not impact efficacy of the label-recommended regimens. So like the Harvoni regimen, there really is no need and no recommendation to screen for the presence of natural polymorphisms to guide the use of the Vicuripac regimen. Now, the story, as you heard again from the previous speaker, the story was a little bit different with the Daclatasvir Sofosbuvir regimen. This is showing an analysis of the ALLY-3 registrational trial that was conducted in patients with genotype 3 infection. And as you can see, those with the Y93H polymorphism in NS5A had a pretty dramatically reduced SVR rate of 54%. Pretty small numbers, but we did see a consistent trend in both cirrhotic and non-cirrhotic subjects. So there was this pretty clear impact of this polymorphism on treatment outcome. But what was also interesting from this analysis is that there did not appear to be major resistance consequences of failure for those patients with that Y93H polymorphism because they really did not develop additional treatment emergent substitutions if they already had that polymorphism. And we think that that's because Y93H by itself is probably enough to confer clinically relevant phenotypic resistance. It really confers a very large hit on Daclatasvir antiviral activity. Now, we had kind of a challenging regulatory decision to make here with this signal regarding the need for screening for this particular polymorphism. And ultimately, the label is silent on a recommendation to screen for this population. And that there are a number of reasons for that. One of the reasons I already mentioned is that the lack of clear resistance consequences of failure. And then also at the time of initial approval, there was not an assay that was commercially available to even screen for this polymorphism in clinical practice. And even today, the alternative treatment options for, at least the alternative interferon-free treatment options, are not ideal for genotype 3 patients with a Y93H polymorphism. So for those reasons, the label is silent on a screening recommendation, but the data are presented in the label so that on a case-by-case basis, a clinician can decide to screen for this polymorphism to guide treatment decision-making. And today, there are some assays that are commercially available for genotype 3. Now, the story gets really interesting with the Elbasvir Grazoprevir regimen. This is the Merck Zepatier regimen that was recently approved. Elbasvir is an NS5A inhibitor. Grazoprevir is an NS3 protease inhibitor. And again, here we're just talking about genotype 1A patients. This regimen was highly effective in genotype 1B patients, so there were really no major resistance considerations for genotype 1B. But for genotype 1A, there was this pretty clear signal with the 2 DAA regimen when it was dosed for 12 weeks. Patients with one or more of these NS5A polymorphisms at these 4 key positions tended to have a lower SVR rate compared to patients without those polymorphisms. Not surprisingly, there was some variability in the impact of these polymorphisms, but for each of these 4 positions, there was a trend of a lower virologic response rate compared to those without polymorphisms. What was also concerning from these trials is that nearly all virologic failures with these polymorphisms gained additional treatment-emergent resistance-associated substitutions in NS3 or NS5A. And in fact, most patients actually gained additional substitutions in both drug targets. So we were concerned about the potential resistance consequences of failure in this population. Now, fortunately, the sponsor had another trial in which an arm of subjects received these 2 DAAs in combination with ribavirin for a longer duration of 16 weeks. And in that group, there were 6 patients, a grand total of 6 patients, who had one or more of these NS5A polymorphisms, and all 6 of those patients achieved SVR. Now, it's difficult to make a big regulatory decision based on 6 subjects, but we were confident that this regimen was probably a better treatment approach for these patients, mainly because we already knew that a more intensified regimen can help to overcome the impact of resistance. And also, these 6 patients represented a pretty difficult to treat group of subjects. They were all treatment experienced. 2 of them had cirrhosis, and 2 of them actually had multiple NS5A polymorphisms, yet they all achieved SVR. So we were reasonably confident that this regimen would be a better alternative for patients with one or more of these NS5A polymorphisms at baseline. So I think we had a pretty clear case for that 12-week ribavirin-free regimen where we had a clear impact on efficacy. We had something that impacted 10 to 12% of the genotype 1A population. There are now multiple laboratory-developed tests that are commercially available to detect these polymorphisms in clinical practice. They were even in use at the time of review of this regimen, or at least one of those assays was in use. And we think there are reasonable alternative treatment options. There were potential resistance consequences of failure, and the retreatment options probably depended on the individual patient and what kind of resistant variants they developed as a result of treatment failure. But certainly the currently available DAAs were probably not ideal for everybody, and then the clinical consequences of failure, again, probably just depended on the individual patient. So we had a challenging regulatory decision to make here, and this is ultimately what the label looks like, what we agreed with the sponsor on for language regarding the screening for NS5A polymorphisms. So for genotype 1A patients without NS5A polymorphisms, this represents about 88 to 90% of the genotype 1A population. You have this really nice once daily, ribavirin-free, 12-week regimen, and those patients can expect to achieve a very high chance at achieving SVR. It was about a 98% chance based on clinical trial results. And then for the smaller subset of genotype 1A patients that have NS5A polymorphisms, we recommend a more intensified regimen of the Zepatier combination plus ribavirin for that longer duration of 16 weeks. Now, this represented the first example where pre-treatment screening for resistance-associated polymorphisms is strongly recommended to guide the optimal use of an interferon-free regimen. And soon after the approval of this regimen, the treatment guidelines were updated, and they were actually quite consistent with the prescribing information. So we felt that we had a pretty good data-driven approach towards handling this issue, and a reasonable approach that can be used in clinical practice. And then we saw these data with the Daclatasvir Sofosbuvir data. Again, we're talking about genotype 1A patients, the same NS5A positions as we considered with the Merck Zepatier regimen. And we see that we learned from these trials, this is from an analysis of the Ally 1 and Ally 2 trials, that were used to expand the indication of this regimen to include genotype 1 patients. And this regimen was quite effective in patients with genotype 1 or genotype 1A specifically, but there was this one small group of genotype 1A patients with cirrhosis who had one or more of these NS5A polymorphisms. We have our magic number of 6 again, trying to make decisions based on 6 patients. And in this small group, only 2 of those 6 ultimately achieved SVR. So there we had this signal, and like the Elbasvir Grazoprevir regimen, most of these failures developed additional treatment-emergent substitutions. And we were concerned about making decisions based on such a small number of subjects, but we did have evidence from other trials or populations that Daclatasvir-based regimens can be impacted by the presence of NS5A polymorphisms. And we heard from Dr. Kodalil mentioning that the genotype 1B Asunaprevir Daclatasvir regimen. I mentioned the genotype 3 Y93H impact. So we had a trend that polymorphisms can impact Daclatasvir-based regimens. And then I also mentioned evidence from the Optimus trials of Cimeprevir that disease status or cirrhosis status can also influence the impact of baseline polymorphisms. So we were reasonably confident that this was a real signal, and then for all practical purposes, these data indicate that this is not a well-supported alternative regimen to the Merck 12-week regimen for genotype 1A cirrhotic patients with NS5A polymorphisms. So again, we had to make kind of a challenging regulatory decision here, and ultimately, this is what the label looks like. So here we actually used a little bit softer language. So the language is consider screening for the presence of NS5A polymorphisms. And this softer language takes into account kind of the weakness of the data, and it allows clinicians to kind of decide for themselves whether or not they really want to screen and use those screening results to guide treatment decision making. And unlike the Elbasvir Grazoprevir regimen, these treatment recommendations are not consistent with the treatment guidelines. In fact, the treatment guidelines authors were able to take advantage of observational cohort data in which subjects received a longer treatment duration that was really not evaluated in clinical trials, at least not the trials that we reviewed. And based on those data, they actually recommend a more conservative treatment duration of 24 weeks for patients with cirrhosis, irrespective of the presence of NS5A polymorphisms. So presumably, that more intensified or longer treatment duration would help to overcome the impact of NS5A polymorphisms. So since this is a clinical pharmacology audience that's probably interested in HCV pharmacodynamics, I thought I would talk a little bit about the clinical relevance of baseline phenotype. Now, some have proposed using a phenotypic assay to determine which polymorphisms are ultimately clinically relevant. And what I'm going to argue over the next few slides is that baseline phenotypic resistance may be associated with reduced efficacy, but the lack of a baseline phenotype does not preclude clinical relevance. And to make this point, I'll go through 2 NS5A examples that I've already brought up that illustrate the relationship between baseline phenotype, clinical impact, and treatment-emergent substitutions. So for Elbasvir Grazoprevir, what I'll focus on is the genotype 1A L31M polymorphism. This was associated with a 38% SVR rate, but in a stable cell line replicon assay, it actually did not impact Elbasvir activity at all. So there was no clear phenotypic impact in that assay. And my understanding of the replicon assays is that that's actually the more reliable approach for measuring phenotypic activity of a drug. But in the other aspect of the replicon system, if you do a transient transfection assay, you do see a tenfold, the sponsor reported a tenfold reduction in Elbasvir activity due to the presence of this L31M change. But I'll actually argue in the next slide that this tenfold reduction is probably not all that relevant when you consider that Elbasvir is a picomolar drug. But despite this modest impact, it is still considered a high-fold change RAV according to the treatment guidelines. So I'll contrast this story with the Daclatasvir Sofosbuvir genotype 3 Y93H polymorphism. And again, this was associated also with a reduced SVR rate. And in contrast to L31M in genotype 1A for Elbasvir, Y93H conferred a very large reduction in Daclatasvir activity in genotype 3. So to put this into a kind of a pharmacodynamics perspective, this is what the EC50 values look like for Elbasvir. So in a wild-type genotype 1A replicon, we're talking about single-digit picomolar activity. I mean, it's just a ridiculously potent drug, like a lot of other approved NS5A inhibitors. There is a little bit of a serum adjustment factor that should probably be accounted for Elbasvir. And then if you put in L31M and consider that worst-case scenario that it confers a 10-fold reduction in Elbasvir activity, we're still talking about an EC50 value that's sub-nanomolar. So that drug is still quite potent against this particular variant. And if you put that into consideration with the drug levels that are actually present in a treated individual, that EC50 value is still multiple orders of magnitude below the drug levels that you see in an infected individual. So I have a hard time believing that that 10-fold reduction by itself is enough to confer clinically relevant phenotypic resistance to Elbasvir. Now, if you contrast that with Daclatasvir, again, we have in a wild-type genotype 1A replicon single-digit picomolar activity, and there's no real serum adjustment that has to be considered for Daclatasvir, but in genotype 3, the drug does have slightly reduced activity, but it's still sub-nanomolar. But then when you put in the Y93H change, you get this really dramatic shift in Daclatasvir activity. And in this case, this does approach clinically relevant drug concentrations. And I'll point out that the y-axis on the right is actually an order of magnitude larger, just to further emphasize how big of a shift that Y93H change is. And all of this makes sense when you see what emerges in patients who experience virologic failure. So for the Elbasvir containing regimen, those who have NS5A polymorphisms, when they fail, they have additional substitutions emerge in the viral population. And this is consistent with the fact that L31M by itself is not enough to confer clinically relevant phenotypic resistance to Elbasvir. But for Daclatasvir, those who have Y93H and experience virologic failure, they do not have additional treatment emergent substitutions. And this is consistent with the fact that Y93H is enough on its own to confer resistance to those clinically relevant drug concentrations. So to put all of this together, how can a polymorphism without a clinically relevant phenotype still be clinically relevant? And I'm going to kind of illustrate this as kind of a qualitative concept. I'm not a mathematical modeler by any means, and I'm sure there are people in the audience who could do a much better job at putting numbers behind this. But I'll just describe this just as a general concept and think about the Perlson studies that tell us that everybody has underlying viral populations that that have amino acid changes or at least nucleotide changes that are generated spontaneously all the time. So somebody who has a wild-type predominant viral population will have some level of an underlying population that carries a particular resistant variant. And in this case, I'm using L31M as the example. This is the viral population that is associated with virologic failure, but that particular variant is still susceptible to Elbasvir. And then there might be some other low-level population that's present that carries an additional change, and we've learned from other NS5A inhibitors that it's really sometimes a combination of NS5A substitutions that can really synergize to confer really dramatically reduced activity of an NS5A inhibitor, and it's these combinations of changes that really might be necessary to cause resistance to that particular NS5A inhibitor. So in somebody who starts off with a wild-type population, they may have some low-level viral population that carries one or multiple NS5A changes, but they still have another drug in the regimen in the context of the Elbasvir Grazoprevir regimen, and the chances that they have that they have an underlying viral population that is resistant to both drugs in the regimen are quite minimal. And I think this helps to explain why somebody with a wild-type predominant viral population responds so well to this regimen. But if you take the patient population that has an L31M predominant virus, again, this virus is still sensitive to the NS5A inhibitor, but what you've done is you've reduced the overall resistance barrier to the combination. So we've basically taken the resistance one step closer towards resistance to the entire regimen. So there's a greater chance that you'll have a higher level viral population that carries multiple NS5A changes that confer phenotypic resistance to the NS5A inhibitor, and then a greater chance that you might have an underlying population or spontaneously generated population that carries resistance to both both of the drugs in the regimen. And this is ultimately the viral population that we're concerned about. This is the population that leads to failure, and it's also the population that we see emerging when these patients do experience virologic failure. And I think that helps to explain how a polymorphism that really doesn't have a major phenotypic impact can still be quite clinically relevant, at least in some circumstances. So I'll just very briefly touch on retreatment following DAA failure. I think Dr. Codolil covered this topic quite well. And I've shown this slide at previous presentations, and my pie chart there basically is just as a general concept. Most patients who receive a combination DAA regimen will do quite well, but there will be some subset that doesn't do quite so well. And I think that piece of the pie probably needs to be a little bit smaller now, probably at the point where I can't even fit the little frowny face. But I think that the same general concept still applies even with some of these really effective regimens, in that when you're thinking about retreatment of these patients, not only do you have to worry about any potential resistance that came up from that prior treatment failure, but all of those baseline characteristics that reduced efficacy of that first-line DAA regimen will carry over to the next round of treatment and will have to be addressed with that next treatment regimen. And for this reason, I think we have to be quite aggressive and strategic in treating these DAA failure patients. And as we heard from the previous speaker, there are quite effective strategies now, fortunately, for retreatment of DAA failures. And I'm not going to show any data. I'm just going to highlight 3 general strategies that have been shown to be quite effective for the retreatment of DAA failure patients. So the first one there is simply using a more potent, non-cross-resistant regimen. We have very good examples of this that are even approved and available today, such as Sofosbuvir plus an NS5A inhibitor for somebody who experienced virologic failure with a protease inhibitor. That regimen is perfectly effective in that particular setting. You can also take an intensified regimen, such as adding ribavirin, another DAA, or maybe give a longer treatment duration. And there are also multiple, at least small-scale studies showing that this approach also is quite effective for the retreatment of DAA failure patients. And then in the pipeline, we have combinations of novel DAAs with activity against DAA-resistant viruses. And the data coming from some of these programs is just phenomenal, showing very promising efficacy in DAA failure populations, including those who are NS5A failures or multiple class DAA failures. And even in those who have high-level resistance to multiple classes of DAAs. So I think the future looks quite bright for the retreatment of DAA failure patients, but there are, I think, just a few remaining questions. And like everything else in the field, it's probably just a matter of months before some of these are addressed. So one of the questions that I still have is, what is the precise impact of resistance-associated polymorphisms or substitutions and the need for resistance testing in DAA combination regimen failures? Again, I think we'll have some pretty good insight on this over the next few months. Also, what is the optimal retreatment for genotype 3 patients who have failed an NS5A inhibitor? I think the data are a little bit behind in that particular group of patients. I didn't say anything about genotype 4 or genotype 6. These genotypes are much more diverse than genotype 1 and genotype 3. And I'm not sure if we have a full appreciation yet of the scope of subtype diversity within these genotypes and how that impacts DAA efficacy. But again, I think it's just a matter of time before we have a better sense of that. And then I think there's still some question in the field about what is the optimal treatment for patients with more advanced cirrhosis with or without the presence of resistance polymorphisms or substitutions. Okay, so I'll just stop right there, and I'll thank the following FDA review team members, including the clinical virology and clinical reviewers, as well as the division leadership. And I'll just point out that a number of the analyses that I showed were actually conducted by the clinical virology reviewers that are listed there. So I thank them for their contribution to these slides. And I'll just stop there, and I'll take any questions. Thanks.